Hello, my name is Leslie Vnechak. I'm a speech-language pathologist, and this is my colleague.
Hi, I'm Jennifer Scott. I'm a dietitian, and I work with Leslie over at the Penn Comprehensive ALS Center.
We're here today to discuss our roles as speech-language pathologist and a dietitian within the ALS clinical setting, particularly in the area of tracheostomy and ventilation.
Yeah, so I'll get started and talk a little bit about my role as a dietitian and what my goals typically are for my patients. Getting adequate calories is very important. One of my goals is for weight maintenance. There is not a lot of research with regard to nutrition in ALS, but we do find that weight maintenance is protective. So a lot of my role and focus is to try and help patients get in adequate calories. This may change following a trach. So some patients may have a change in their swallow following a trach, which some patients may also receive a feeding tube. And this can be different from patient to patient. Patients may be able to eat the same following a trach, or they may have a change in their swallow and require some backup nutrition from a feeding tube. And we'll talk a little bit about this as we go through kind of our talk. One of the things we also may bring up is altered consistencies and trying to support just the ease of swallowing, and that is something that I will let Leslie talk a little bit more about as far as how we determine that for each patient.
So first I'd like to start off with that each patient's process and presentation is different. So an individual evaluation is very important. So when we see a patient within clinic, we'd like to kind of do a thorough swallow evaluation. We start off with a clinical assessment. And what a clinical assessment looks like, we will take a look at the oral muscles of swallowing and speech and see how the muscles are working. We will also take a look at the patient-reported and family-reported swallowing difficulties. I'd like to know what's going on at home, what is difficult, what is easy, what's working for you. And then from there, actually doing a clinical assessment with food or liquid to see what is going well and maybe what isn't going well, and how maybe I could tweak some things or make recommendations within the clinical setting to see if it helps the swallow function. After that clinical assessment, I tend to recommend a gold standard would be an objective swallowing assessment. And there's two types. Depending on how someone is presenting within clinic would be what assessment we would recommend in collaboration with the medical team. There is a FEES study, which is a fiber optic endoscopic evaluation of swallowing. And that is done within an outpatient setting within a clinical office. It could be done by a physician in collaboration with a speech pathologist. And what that is it's a nasal endoscopy tube that is threaded through the nasal passage to get an aerial view of the laryngeal area. The laryngeal area is the entrance into your airway. So once that camera is in place, food and liquid is given to the patient, and we see what's happening. Is food and liquid going toward the esophagus, that's what we want, or is food and liquid going towards the airway? If it is going towards the airway, are there strategies or postures or altered consistencies that we can introduce to prevent that from happening? The other standardized assessment or objective assessment would be a modified barium swallow. And that is done within radiology. That is a study that is basically like a moving x-ray. It's a movie of your swallow, and different consistencies and postures are implemented during that study to see what's going to help the individual swallow a little bit more safely and easily. Again, a speech pathologist is involved, and it is taking food and liquid by mouth or barium it lights up and we can see where it's headed. The goal is for food and liquid to head towards the esophagus, which then goes to the stomach. But sometimes we see some things headed towards the airway, and we like to intervene live to see what would help to make that swallowing more comfortable, but also the safest way to swallow. And I alluded a little bit to some strategies and to altered consistencies. And when we say alter consistencies, this is different for everyone. It may change during the day, it may change with fatigue, it may change with positioning. But alter consistencies would be either making liquids a little thicker, so it slows down the flow of the liquid, so it's easier to swallow, or adding moisture to food, so it also is a little bit easier to swallow. The recommendations of alter consistencies or strategies or different postures to use are very individualized per the person. So it's very important that each person gets their own evaluation and discuss with the medical team about what's safest for that individual. At times, getting all adequate nutrition and hydration is not always applicable for everyone, and they may need support of a feeding tube. So I'm going to ask Jen to elaborate a little bit more about the feeding tube procedure.
Yeah, so like we talked about, those who opt to get a trach will oftentimes also receive a feeding tube. The name would be called a PEG, or a percutaneous endoscopically placed gastrostomy tube. And this is something that could be done in a procedure at the same time. That way you would only receive anesthesia one time, or it could be done separately. And this is something you would discuss with your doctor about, what would be best for you. But typically, if you receive a trach, you may also receive the feeding tube. The feeding tube would be there, like I mentioned, to support you, to make sure that you're able to get adequate nutrition and hydration. And it's not to say that you couldn't eat with a feeding tube. There's no contraindication when you get a feeding tube with eating, and that would really solely be based on what Leslie was talking about, how your swallow is doing and just your clinical presentation there. The feeding tube itself is a small, about a 1/4 inch flexible tube, and when it's placed, it will extend from your stomach to the outside. So this is something that you would use, and liquid would go through your feeding tube. So, think about like the consistency of a milkshake, or if you ever had, like an Ensure or a Boost, that consistency would be what I would recommend is what would go through your feeding tube. In addition, those feeding tubes can also use solely for hydration purposes, and some people receive them and really use them initially just for water to make sure that they're getting adequate hydration. And also your pills can be flushed down a feeding tube as well. So, depending upon what medications you're on, and you can consult with, the doctor or the pharmacist, but if your pills can be crushed, they can be crushed and flushed down a feeding tube, or if they can be changed to a liquid form, that also can be placed in the feeding tube. So this is really something, that is very individualized, like Leslie said. I mean, everyone will probably use their feeding tube differently. Some patients, it might be used as their sole source of nutrition. Others who are eating well or really don't need it that much may only use it sporadically or for pills or hydration. And this is something that can change, and that's why it's important to kind of discuss this with your team, with your dietitian, to kind of feel, to see how you can best utilize this, feeding tube. And also what goes through the feeding tube, and this is something that you can talk with your dietitian about, which is the appropriate nutrition formula that that they would order, that you would use for your feeding tube.
Something I would like to touch on that I had forgotten is that there is a risk of aspiration sometimes after a tracheostomy. So it is important to have these evaluations to see if food or liquid is falling below the vocal cords and into the lungs. Another take-home point I'd like to add to this is that your swallowing may change not only throughout time, but it may also change throughout the day, depending on fatigue. So forming a relationship with your medical team and discussing different changes in any presentation is very important to ensure your quality of life, and we are definitely here to support you through that.
So, yeah, I think that was it. I mean, for the feeding tube part, but maybe Leslie can talk a little bit about the communication.
Yes. So I do think there's going to be another section focusing on assistive technology, but I did want to address communication on a tracheostomy and when you're ventilated. After the procedure, again, it's consulting with your medical team, and it is a group decision with everyone on how to help you communicate best. Some patients may be able to tolerate a speaking valve, which is a valve that would which is a valve that would allow airflow to go to the vocal cords so you could verbalize. Some people may have difficulties tolerating that valve, and we discuss different types of communication, alternative communication, such as gestures, eye blinks, communication boards. We also get into more like speech-generating devices that would communicate for you. So again, that is an individualized evaluation with your medical team. All team members are a part of that, from speech pathologist, occupational therapist, physical therapist, physicians, to provide the support and help you communicate the best way for you at different times of the day and within your life.
I guess we can kind of wrap up, but when making decisions, regarding your health, it's very individualized, and you want to make sure that you have this team or different people that you have to support you. And our role here is to support you and to help you make these decisions that are best for you at that time.
So thank you to the ALS Association for this invitation to speak with all of you about this important topic, and have a wonderful day.
Thank you.